Okay. Okay, so we're here to talk about the fussy baby and how chiropractic can help. My name is Dr. Jennifer Teasdale. I'm a chiropractor. I'm just going to flip forward here so we can see all about me before we get started. So I'm a pediatric and perinatal trained chiropractor. I've been practicing chiropractic in Calgary for 14 years. I see children and moms and families, as well as athletes and kid athletes in my practice. I assess and treat infants for torticollis, which is head tilts, plagiocephaly, which is head shape issues or flattening of the back of the head or one side. I also assess and treat tongue ties, and that's the fancy name for tongue ties beside it, developmental milestone delays, as well as feeding struggles. My approach is very gentle, movement-based, and educational. And as you can see below, we don't need to go through all of the things that I've done, but that's some of my education that I've taken over the years for kids as well as moms or moms to be. Yeah, so we're going to get started. So a lot of the times when we talk about fussy babies, they're in my office because of maybe something that you've read online, maybe a Facebook page. Someone has said, oh, take your baby to the chiropractor. And you're sort of at the end of your rope. So you're not quite sure what the chiropractor is going to do, but you're willing to do anything that might just help. So the fussy baby may look like some of these. Sometimes fussy babies look like all of these. And we're going to define a little bit more about what a fussy baby, what's going on with the fussy baby actually. So let's just talk about some of the things that I see when it comes to fussy babies. So when they come in to see me, their parents or you guys are usually, like I said, at the end of your rope, you're exhausted, you're overwhelmed, you've been to the doctor, you didn't find it particularly helpful, at least not for those 3 a.m. wake up calls, and you're not really sure what to do. But these are some of the things that we see or you see at home. So we see typically, when we talk about fussy babies too, it's not typically beyond 6 months, I would say. You're usually in that 0 to 12 week, 16 week stage. And these are the things that we see. So we see some body tension, whether that's your baby just looks like they're not relaxed. It would be a really great way to describe that. They're often have their hands closed in fists. Their legs are straight and they just look like their whole entire body is rigid. What comes with this is often difficulty feeding. So that might not be so much bottles, but it'll be more breastfeeding at the beginning, where it becomes a real struggle for both you and baby. These babies can sometimes be hard to burp as well. So that means that they have extra gas in their belly, and that can cause a host of different things that you'll see here in just a few minutes. They also usually have sleep issues that go well beyond what is expected. So we'll talk a little bit more about what is expected in the first 6 weeks, because I don't know that we really know what the norms are for that. We hear that our friend's baby is maybe sleeping through the night at 6 weeks, and our baby is barely making it past 2 hours. And then we make some comparisons around that. So there are sort of some normative values that we'll go through. You've either had a baby that had a tongue tie clipped in hospital because they recognized that breastfeeding was going to be an issue right off the get-go, or you've got one that was missed, and you don't necessarily miss an anterior or a front tongue tie in the hospital, but you can definitely miss a posterior tongue tie upon bringing the baby home. And then all you know as a mom is that your baby is really struggling to feed. They're falling asleep at the breast. Your nipples are cracked and sore and go beyond painful, and more things like that. They also have reflux that goes well beyond what normal is. And I'm going to define what normal reflux is, as I don't think anyone really knows what normal is. There is a certain amount of spitting up that babies do that's considered completely well within normal. And then there's over and above that. And we'll talk a little bit about silent reflux as well, because it's something your doctors are telling you all the time. But again, I don't think that's well defined for the parent to really truly understand. These babies sometimes won't take pacifiers. Sometimes they do. and sometimes they don't. And it's usually strange when they don't, because all the other babies are taking pacifiers. Why is my baby not taking a pacifier? And then I also alluded to the trouble with breastfeeding. So there's often a trouble with breastfeeding, whether that's mom's comfort, babies struggling, or it's usually a combination of both. They're usually gassy for sure, if not constipated as well. So we'll define what constipated is, because there's some misinformation out there as well. Sometimes these babies don't like to be put down either. So they're constantly wanting to be with you or held all the time. And that means that they're contact napping and contact sleeping at night, which means they're on you and sleeping. And then you're just, as a parent, you just have an overwhelming sense that something is wrong and no one is listening, or no one is helping you in a way that makes your day-to-day life easier with baby, or not so much easier, but that baby is eating. Those are one of our health parameters, right? Are we eating? Are we gaining weight? Are we pooping? Are we sleeping? All of that kind of stuff. So your baby may have one of these, your baby may have all of them, your baby may have 5 of them, but you definitely feel like something just isn't quite right in those first 6 to 12 weeks. So what's expected in the 4th trimester? So the 4th trimester is the first 12 weeks. It was Dr. Harvey Karp that actually started the 4th trimester. I don't know that I necessarily believe what he said about the 4th trimester. He thinks babies are born a little too early and they need to be inside for another 3 months. But I really feel like that's something a man would say, is you've never actually had a baby on the inside for 9 months and you're about ready for them to be evicted. However, I do believe in the 4th trimester, and that's a time where baby's now on the outside, and you're trying to learn what your baby needs, and that learning curve is very, very steep. So I said steep learning curve for parents is usually what's expected in the 4th trimester. Crying is expected, lots of crying, babies trying to communicate what's going on. Our fussy babies often cry because they're trying to let you know something isn't right for them. Then there's also what's to be expected is spitting up. That's what I talked about before when I talked about reflux, and I want to define what reflux is. And then this is also normal. Baby's waking every 2 to 4 hours, and that's based on whether the baby is breastfed or formula fed. So if the baby is breastfed, it's waking every 2 hours. If the baby's formula fed, it's waking between 3 to 4 hours. But the baby should be sleeping anywhere from 14 to 18 hours. So again, 14 hours might be on that breastfed baby side, 18 hours is what's going to be on that formula fed baby side. And that's not always true, but that's sort of some normative values that you can take with you today. And then also what's expected is you're learning how to breastfeed. And this is often why people are coming into my office, or they're seeking lactation consultants, or they're back in their family doctor's office, is because they're struggling to breastfeed. They're pumping, or they're formula feeding, or they're doing a combination of all 3. And then what's also expected is that tummy time is happening, but it's happening in, just a couple minutes spurts. Sometimes our babies come out of the womb and they're great at tummy time, and other times it's difficult for them. So sometimes that even can be a little bit of a yellow flag that they're maybe not doing as well as they could be. But yeah, so that's what's expected. So let's talk a little bit about crying, because I said it is normal and expected for your baby to cry. And it will always be normal and expected for your baby to cry throughout their life span. They just do a lot more of it in those first 12 weeks. So when crying is excessive, so usually we do a rule of 3s when it comes to colic, because we often label things like we have a baby that cries. So we say, it's colicky. Well, this is what colic is. Colic is 3 hours of inconsolable crying per day, which is a lot. It's 3 days, more than 3 days a week, and for 3 weeks at a time. And so oftentimes when we go through, when I've got a parent in the office and they're saying, well, I think my baby has colic, and we go through the rule of 3s, it doesn't stand up, it doesn't hold up for them. Some of it's true, but not all of it is true. So crying obviously is overwhelming to our central nervous system as parents. We are in a panic to help our baby. So it can feel like sometimes even just 15 minutes of crying can feel like a month of crying solid, because you're just trying to, get through and you're exhausted. So that is what colic is. So 3 hours of inconsolable crying per day, 3 days a week for more than 3 weeks. So what is colic? Research suggests that colic may be due to some GI issues. So these can include allergies, such as like a milk protein allergy. Sometimes it's often feeding technique. So how we're feeding our babies, whether they're taking in any extra air when they're feeding. And then also GI dysbiosis, or which is just honestly not good gut bacteria, really is what it comes down to. And we're often putting our babies quite early on a probiotic anyhow. So that's something I would say parents are doing so well, is by the time they're getting into my office, so whether that's 2-3 weeks, they're already on a probiotic. So that's something that we're already trying to cross off that GI issue list. So typically colic resolves around the 6 to 12 week mark. So when we look at the data, 25% of infants that have colic at 6 weeks. So let me just read that better. 25% of infants have colic at 6 weeks. However, when we look at 10 to 12 weeks, only 0.25% of those babies have colic. So it starts to settle down in that 6 week period. But those 6 weeks can feel like years, especially when you've got that steep learning curve as a parent, or if you have another kiddo and that other kiddo was so different than this kiddo, those 6 weeks can feel like forever, and you even know something is wrong because the other kiddo was so easy in the first 6 weeks. So that's colic. Let's talk about what's normal or not normal for reflux. So reflux is spitting up, and there is a certain amount of spitting up that babies should do. All babies will spit up. So what is too much? And that's when we can start to define reflux. It's greater than 3 to 5 times a day. And it's greater than 2 tablespoons each time that our baby is spitting up. And then I've also made a note about chronic projectile vomiting. So chronic projectile vomiting is actually not normal, which I think we all sort of know, especially when there's no weight gain or there's weight loss. Usually we've got our babies into the doctor and on our way to pediatricians by that point. However, occasional projectile vomiting is quite normal, as long as there's no issues around weight gain or weight loss with that. So no weight gain, which is plateau, or a weight loss, but the occasional projectile vomiting is to be expected. Okay, so I really like this slide because I don't think parents have ever been given any normative values around what reflux is. Okay, moving on.
Excuse me, Dr. Jen. Cleo did have a question. Do you want to pipe in and ask it, or maybe I'll just read it from the chat. It was regarding the crying. Is that a commute? Is that like 3 hours within a 24-hour period,
Mhm.
or
Can
what?
be
What is
all together, which I hope that it isn't. Yeah, exactly. Or it can just be like 3 hours in a day. So collectively, I think is the word we're looking for. Is it an hour? Is it how many hours a day is it? So you've got to kind of pay attention to that, but it shouldn't be 3 hours straight. However, if it is, it's going to be really tough. Good question. I thought about that actually, about saying that. But yes, that's a great question. I'm glad you asked that. So let's talk about constipation, because this is another question I get in the office with families and parents all the time. So what is constipation when it comes to babies? I usually get told from families, moms and dads, that they were told by the nurses or the doctors that 10 bowel movements in one day or 1 in 10 days is normal. And so what do you guys think about that is my question, because I don't necessarily, well, I know that that's not true, number one. And I want us to think about our own bowel movements. And I say, this is sort of the joke that I say in the office, is I'm pretty sure that there was a bachelorette in paradise that was airlifted from paradise because she hadn't pooped in 10 days. And she was airlifted and taken to surgery in the States. So we know for sure that the 1 in 10 days is not normal. But we also know for our own selves, like that's all we think about if we haven't had a bowel movement. It's everything that it encompasses yourself. You are focused on it, especially if it's been more than 3 days. So now imagine you only weigh 8 pounds or 10 or 12 pounds, and you're teeny tiny, of course you're going to be uncomfortable. Of course you're going to be upset. And so constipation is this. This is coming from the American Family Physicians. Constipation is defined as having fewer than 3 bowel movements a week, which I think we can all get on board with this. It's hard, it's lumpy, and it's difficult to pass. That's what I should have said, was difficult to pass. There's difficulty passing it. I wouldn't say that your baby's stool is necessarily going to be hard and lumpy, but it certainly can be. It's mostly just that they haven't had a blowout, right? It's been, a couple of days, and usually we're expecting a blowout, and then there's no blowout. So it's usually still going to be soft, but you'll notice that they are uncomfortable. Maybe their belly is distended, maybe they're pushing, maybe they are gassy, or maybe they're struggling to pass gas. Maybe they're crying when they're pushing to have a poop. Maybe they're crying to pass gas. That's constipation, and that's when it warrants further evaluation. So then I grabbed a table that I thought was a really nice table, because again, it's that normative value we don't typically see when it comes to our kiddos. So I don't know if we can see this. I'm got our pictures up here. You guys can all see that. I'm just going to pop our screens down. Yeah. So when we don't necessarily need to talk about older kiddos, but we talk about age. We talk about how many, the mean number of bowel movements per week, and then the mean number of bowel movements per day. So and I like this one because it talks about the difference between a breastfed baby and a formula-fed baby. So a breastfed baby should have anywhere from 5 to 40 bowel movements in a week, or about 2 to 3 a day. And I think that makes sense, right? Usually after a feeding as well, about 30 minutes after a feeding would be expected. And formula-fed babies are a little bit lower, but not by much. So 0 to 3 months, formula-fed babies are anywhere between 5 and 28 bowel movements, which again is still 1 bowel movement a day if we look at it that way, or every other day. And then the mean number of bowel movements per day would be about 2. So I really like this graph because it helps us understand what's normal. And then when we're in our doctor's offices and we're getting told, and it doesn't have to be just doctor's offices, I'm certainly not wanting to point them out, but just even out in the community, in our Facebook groups and in our mom chats and things like that, 1 in 10 and 10 in 1 is not. I don't know where this came from, but I wish we could just lay that guy to rest, because I don't believe that's true. And I see so many parents in here asking me, do you think my baby's constipated? I just feel like it is, and it seems so uncomfortable, and you're crying all the time. And I'm like, yeah, absolutely. If we have not pooped in 5 days, we are not a happy camper. So anyhow, that's constipation. Okay, I'm just gonna move my little screen up and around again, guys, and then we'll carry on. Okay, so gas and distress, around gas pain and distress. So what does that typically look like? It looks like straining to pass gas. It looks like excessive gas after feeding. It can be excessive gas with no productive bowel movement, so just lots of toots but no poops, and that goes on for a few days. Or it can be painful to pass the gas, like I had said as well too. I put after feeding, but it can just be in general too. So painful to pass gas. They're maybe crying, or they're red in the face, or they just look unhappy. And then you also start noticing that the baby's settling after passing gas. So they have a toot, and the next thing you know, they're just happy as a clam. So when we talk about gas, pain, and distress, I'm just going to pop onto the next one, because I want to see if no, okay, I'm right on to something different. So when we talk a little bit about gas, something that I'll bring up after the next slide is burping. So what I've noticed in the office over the last decade or so is that it's almost like burping has become an art, and we're not necessarily trying different things to get our babies to burp. So we try the one way that we've been taught, or we see our parents or whatever. And then if that doesn't work, it just doesn't work, and we carry on. But those little gas bubbles can get caught in their belly, and they can be really uncomfortable with that. So that can also be another reason for silent reflux, which, instead of putting your babe on some medication from the family doc, just trying to get some good burps out of the baby can be helpful as well. It sounds so simple, but honestly, in in practice, in clinical practice, it's some of the simplest stuff with these kids that works the best. So just going back to basics, and it's like I said, it sounds simple, but man, is it effective. So I've got some different burping guidelines. I've given 3 different ways to burp a baby, and I think there's even one more out there, but we'll get to that slide. Okay, so silent reflux can just be caught gas. Okay. All right. So tethered oral issues. This is a really big one in my practice. It's one that I have extra education around, and I help. I not only can assess, but I can also make referrals and then treat afterwards. So in our community, being the chiropractic community, we often say tethered oral issues. That's not really a common term, I'll be honest. In talking with lactation consultants and physicians, they know them more as tongue ties. Okay, so oftentimes, as I'd said at the beginning, tongue ties are twofold, and they can even be deeper than that, but that goes beyond this talk. So they're either anterior ties. That means that you've got your front part of your tongue has got this extra piece of skin called a frenulum, and it's attached to the bottom of your mouth, and it doesn't allow the tongue to come out. Those ones are caught easily, and they're caught in the hospital or by the midwife right away because the baby won't latch and they already struggle just in like right after delivery. So they go ahead and clip those right from the get-go, and then baby either goes on to be quite successful or baby still struggles after that. Either can happen. The second type of a tongue tie is a posterior tongue tie. So one that's further back. This one is missed all the time. And so you won't see a point on the tongue like this, the way that this baby's picture is showing. The baby actually will have kind of like a flatter tongue when they bring it out of their mouth, if they can even bring it out of their mouth, or if they're even showing signs of the tongue moving at all. And so that's the same type of idea where you have this skin that's taking the back of the tongue and tethering to the bottom of the mouth. But this will definitely create the babies that don't like pacifiers, that have high palates, and that are really hard to breastfeed sometimes if we don't have the exact breast size and nipple length and all of the things. They get a lot more challenging to breastfeed after we've been sent home. And again, those ones are the ones that are missed. Those are the ones that I see in the office 2 to 3 weeks later. And we're talking about whether mom or dad wants to clip, whether mom or dad wants to try different exercises and things and techniques at home. So in my practice, the tongue tie baby may be one of the fussiest babies I see. And it's really true. It's because they're hungry. They aren't good feeders, so they're either falling asleep at the breast or they're busy glugging on the bottle and they've got a ton of reflux because they don't have efficient feeding patterns. They're not always the fussiest baby that I see for sure. No, wait, they are always the fussiest baby that I see, but they're not always the fussiest. So you can still have kind of like I would say a medium fussy tongue tie kiddo. You could have a mild fussy tongue tie kiddo, or you can have the severe fussy tongue tie kiddo. And that's usually the one I hear in the office. It's already crying in the waiting room because they're hungry, or they've got gas, or they haven't pooped, or there's all the things on this list. So feeding issues, like I talked about. Torticollis isn't something I'd mentioned yet, but usually when we have these tongue ties, they start 10 weeks inside of us, so 10 weeks in utero. And so our baby has inefficiently been moving their tongue since on the inside, since the first few months. So that pattern is ingrained and that pattern needs to change. So when that pattern's ingrained, they start doing different things with their neck muscles, because if you can't use your tongue muscle, you have to use your neck muscles and your other facial muscles. So they often have torticollis or a head tilt. And then they don't come out with head shape issues. That's stuff that develops later on for sure. And they definitely have restricted neck movement too. So these babies often will have overall body tension as well. They'll have reflux. They don't want to be put down, or once you feed them, you put them down, it seems like they want to be fed again. It's because they're not efficient eaters. They're not getting enough food. They're not maybe draining a breast. They're definitely hard to burp as well. They either hate or love tummy time, and that just depends on their in utero movement strategy for the tongue motion. Sometimes they use the back of their necks a lot for tilting their head back and like swallowing. And in that case, those are the ones that come out just being so amazing at tummy time, but they also are not good feeders. They often are refusing a pacifier, and that's typically because when we are breastfeeding or feeding our baby, the nipple or even the pacifier nipple has to get up to the roof of the mouth. And if your baby has a tethered oral issue or the tongue is down at the bottom of the mouth, they have a really high palate. And so, in order for the pacifier of the breast to initiate feeding for the baby, the nipple has to hit the top or the roof of the mouth. And if that has a bubble on it or is especially high, that's where we get our issues. And then I said before, they're falling asleep at the breast when feeding because they're tired. They're inefficient eaters and they're tired. And so we want to help them be efficient eaters. So that's kind of where we're going with all of this is you're starting to see some common themes, which is reflux, head shape stuff, feeding issues, and so on and so forth. So I'm just going to flip this through. Hang on. Okay, so a word on burping, and then we're going to carry on with some ways to help. How are we doing on time? I never know. But we're doing pretty good. Okay. So there's a couple ways to burp our babies. Our chest position, which is typical, where we hold the baby against our chest. The baby's chin will rest on the shoulder, and then we're gently patting. But when we're patting, we need to be making like a noise. That's one thing we don't always see, but we want to be making a noise when we are burping our babies. That's key for helping those gas bubbles come on out. And then this one's really good, I find, for the tongue-tie kids, our lap position. So you're laying your baby on your lap with the baby on their belly, because that just helps them a little bit with that gas. You're supporting the head, obviously. And you want to make sure the head's a little higher than the chest as well. And you're just gently patting baby's back or rubbing baby's back in circular motions. Those tongue-tie kids really like those circular motions, but that little bit of pressure on the belly can help these gas bubbles come out. And then there's also the sitting up. So now you're holding baby sitting in your lap, you're supporting their head. Sometimes you're supporting them from the front, from this direction, and sometimes you're supporting them from the back. But again, you rest the heel on of your hand on their chest, and you're just either patting their back or you're making those circular motions as well. So this is something that's really important. And also to note is if you try one way and you don't get a burp, try another way. And if that doesn't work, try the third way. And if you know any other techniques, you just kind of go round and round and round. So you're trying and you're trying and you're trying and you head on back. And by the time you get through, another second round of all these three, you've probably got baby to burp. And then you don't have to worry so much about, is baby going to be fussy when they're laying on their back now because they've eaten, we've stayed awake, and now it's your break time and baby sleep time. And you go to put them on their back and they start to fuss. And that can be, you're exhausted, it's hard, baby needs to sleep, all those things. So definitely important to get that burp before we lay baby down. And then we don't have to worry about that silent reflux or any other pain that they might be experiencing when they go down for their nap. Moving on. So just a little bit about why you would bring your baby to me. Early intervention is best whenever possible. So when our babies are developing, physical and neurological development occurs on a timeline, and that's really true. What that means is that within the first year of life, your baby is developing into tummy time. They're going to start to roll. From rolling, they start to crawl, and from crawling, they start to pull up. From pulling up, they start to stand, and eventually they go and they walk. So everything's time sensitive. Everything's happening within about the first 18 to 24 months. So early intervention leads to better outcomes, and that's just true in my business no matter what. So what that means is if you can get your baby in for a musculoskeletal assessment, because that's what I'm doing, then that would be best if you, especially if you've got any concerns. Early intervention will lead to you being in this office a few times as opposed to coming in, at 6 months. Well, now maybe you've got to come in 6 to 10 times. And at 9 months, maybe you're coming in 12 times. And at 2, sometimes those toddlers are really tough to deal with. So now we're seeing them more on a regular basis, once a month for a year, so on and so forth. So early intervention leads to better outcomes, which leads to less time in my office, which is exactly what parents want too. And then screening your infants for musculoskeletal dysfunctions is safe and beneficial, very safe and very beneficial. So let's scoot on over as to, this is what the research has told us, that why do parents bring their children to chiropractors? So here we are, musculoskeletal complaints, headaches, sprain strains, orthopedic spinal problems, wellness care, and then excessive crying less than 1 week. So, and then that's what the research said, but this is what my clinic And my practice is all about why parents bring their children to see me. Feeding struggles is for sure up there. Tongue ties is up there. Head positioning usually comes in a little later, but it's something I'm catching at feeding struggles. And then tummy time issues, usually around 12 weeks, we start wondering, or 6 weeks. Developmental delays, which actually goes in line with not being able to have tummy time or do it well. Sometimes wellness care. I see a lot less wellness care. I see dysfunctional kids and babes that need my help. Not so much just to be followed because they're growing, but that's nice too. And then some fussiness or colic, and then GI related issues, which can be constipation or, whatever it is, gas and that kind of stuff. Oh, I'm going to go back here. Okay, so how can chiropractic help? Infants have a musculoskeletal system and they can experience pain. 2 to 10 out of 1,000 live births result in some sort of physical trauma. The two most common are clavicle fractures, your collarbone fractures, and that's because that's the only bone in the body that is truly ossified when they are born. And then also brachial plexus injuries. And those are the ones where we've got nerve stuff. So those are pretty significant physical trauma. I see more of that mild physical trauma stuff that leads to before the feeding issues and the torticollis and the gas and the reflux and all that other stuff. Tummy time problems, motor delays. So 73% of newborns have one or more physical asymmetries and dysfunctions. So that's kind of what we're talking about when we're talking about torticollis or flathead syndrome, or we're noticing that they're not doing tummy time well, or they're only looking one way, or so on and so forth. And then we also know this, and this is a very bold statement I've made because there could be a lot of other issues going on here, but 91% of newborns initiate breastfeeding, but only 34% are exclusively breastfed at 6 months, which may indicate some feeding struggles. So I was just talking to a lactation consultant yesterday about this, and I don't love the saying breast fed is best, just because it's not inclusive. It's not a very inclusive statement. And as a new mom, there's just so much overwhelming emotion going on at that time. But I do know, and I see it in the clinic all the time, where women are really struggling to breastfeed. And the information that's given out there in the lactation consultant world is more for you, not really so much about your babies. No one's really looking at baby beyond the tongue tie to figure out how baby can be a more efficient eater, how baby can help you feed them, help me help you kind of thing. And so that's usually where I come in. That's the stuff that I'm looking at. And then we also see 4 to 10% exhibit motor delays or movement dysfunctions as well too. So that's something we can start screening for really early. Like my first screen is tummy time. Like, what does it look like? Are we struggling? And if we are doing okay on tummy time, and then all of a sudden we get to 3.5 to 5 months and we're not rolling, screen number 2. So these things, you can catch these things so early if you're looking for them. Okay. And that's what we want to do. We want to look for them because early intervention is best. Okay, let's go move on to the next one. So a lot of people think, I think there's some sort of like mystical thoughts about what I do for babies. So this and which is cool, there's nothing wrong with a little magic, but I definitely get more of my information from science. And if there's a little magic in the mix, I am grateful. But first off, our visit is a thorough assessment of your baby, about your prenatal experience, your birth history, your feeding history, your GI history with the baby, not yours, your baby's, general health history, movement, and development history. So we go through a very thorough history together. Then we do a physical exam. So this is not, unlike what we would normally do for adults, but the physical exam is infant driven. So it's different in what you're seeing. So we're looking at vitals and basics. We're looking at neurological exams, and it's inclusive of primitive reflexes and postural reflexes. And I know there's a lot on social media about primitive reflexes and whatnot, but our primitive reflexes tell me if we're going to be able to develop in a motor pattern that is going to be healthy. Also, when we have a lag or we see those continue on past when they should go away, it gives me more information about if we're going to struggle down that road. So that does include primitive and postural reflexes, and then your musculoskeletal exam as well too. So that's, range of motion, muscle length, reflexes, yada, 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 all those other different things like that. Hip exam, you can see that's kind of what they're playing around here with hips there too. Okay. Okay. What do I have next? Let's see. Oh, common treatment options. So I pulled this from my clinical experience, but I actually pulled this from the Pediatric Association as well in Canada, just to say that this is some of the things that we are the top things we can do for parents when we have a child, not so much with feeding struggles. It was more directed towards torticollis. But soft tissue therapy, that's probably the number one thing that I use. When you come to a chiropractor, you think that you're going to have cracks and pops done on your back. And with babies, that's absolutely not the case. There's more gentle mobilizations than anything. And then we give you, or we actually give baby exercises. We give you some stretches to give baby. Sometimes we can even use kinesio tape. So that one came directly from the Pediatric Association. But when we have torticollis, when we're like this, or we notice that a foot is dropped down, sometimes as our toddlers start walking, we can use kinesio tape for those kinds of things to help them, and that works really well. And then all of that is just at home advice. We have a lot of conversations, because the conversations you've had in your doctor's office are often ruling out the big red stuff, the big red flag stuff, whereas my stuff is the everyday activities, the daily living, the how do I get through the 6 o'clock in the morning until 9 o'clock at night with the baby that is having feeding struggles, has torticollis, isn't sleeping well. Those are the things that we talk a lot about in here, and I give you as much advice as I possibly can. Okay. Okay. And then the other question, or the other misnomer I see a lot, is what we're doing to our babies as chiropractors. So I wanted to just talk a little bit about what delivery forces are on your baby's neck, spine, body, vaginally. And then I put vacuum delivery. I really struggle to just find cesarean delivery forces. I suspect, as you can see, the two are similar. I suspect cesarean is similar, right? So doctor is pulling baby out, and I suspect the forces are roughly the same, maybe a little more, but I can't say for sure because I couldn't find any good research on that. But the maternal delivery forces, so when we're pushing our baby out, when our uterus is pushing our baby out, it's anywhere between 30 and 50 pounds of force. So that's a lot if we really think about it. It's a lot of force on a spine. And a vacuum delivery force is about 50 pounds. And it's not pounds per force, just so you know, it's just pounds. And I transferred that from newtons as well. So it was just a different study with a different metric. And then for us, our standard of care as pediatric chiropractors, our recommended amount of force is less than 4 pounds. So you can see that there's a significant difference between what your baby is being pushed out and or pulled out with in terms of force, and what we're using in office with force. So we're very, very, very gentle. But I think it brings up a really great point of that's a lot of force, and it's a lot of force on our baby's neck and spine. And so when we talk about feeding struggles and what I do, it's a good time to talk about this now, but I'm often looking at the neck more than anything, because the neck has got so much musculoskeletal tension, usually not so much after delivery, but sometimes, and when they're in my office, that's what I'm seeing. And so something to do, I always like this, if you're trying to think about what it's like for your baby to eat and they have neck tension, if you tilt your head and then close your lips and take a swallow, you'll notice that there's a restriction in your swallow, and they're experiencing the same thing. The other thing that I like to do is if you take your shoulders, because some babies don't have necks. So that tells me right from the get-go, if they're lacking a neck, have lots of rolls in their neck, they have a lot of neck tension. So if we pull our shoulders up towards our ears and then swallow, it's hard. It's hard to swallow. And then if we also add this and a tilt and swallow, it's even harder to do that. So it gives you an idea of what your baby is experiencing when you're feeding them, and you've got to feed them so much, and they're maybe not getting as much food as they could be, and they're not as efficient eaters as they could be. So just something for you to try and see what your baby might be experiencing. And that's it. That is our conversation. I did not too bad, 45 minutes. That was good. So there's my contact information there. I've got my email at the bottom if you have any questions, and then I've got the clinic, the website for the clinic, as well as the number to the clinic too. All right.
Wonderful. Thank you so much. Do you have any follow-up questions, Cleo? Or I know we will put this on recording for reference.
Mhm.
Um, so you'll be able to find the playback link on YouTube within the next 24 hours. It says I have an unstable internet connection. Am I coming and going right
Oh, you're
now?
doing fine. Yeah, yeah. Just before we
Oh,
go,
perfect.
yeah, you're doing fine. Just before we go, Renee,
Yep.
I have a motor milestone chart that I know you do a follow-up email with the people that were
Mhm.
registered. So when you send the link, if I'm just going to send you that motor milestone chart that you can also add in.
That would be perfect. I could put it right into that email. Wonderful. Thank you for all this great information. Even 13 years out, I'm like, oh yes, I remember that. And yes, and
Totally.
yes, very much. So thank you so much. Thanks for everyone that views this, whether it be live or afterwards. And we look forward to what you have next coming down the line, Jen.
Bye.
Bye. Take care.